Hello everyone. Today we are discussing a case. The patient is 55-year-old male, obese, diabetic, complaining of mild central chest pain while he was working near Jazz Hostel. He was taken to nearby Mahita clinic and ECG was recorded. So let's see the ECG. So what is this ECG? First you check the standardization of ECG. In standardization we see that it is one big square wide and two big square tall. So it is a standard ECG. Calibration is standard. Next, we should see the rate of the ECG. In rate, we see whether the rhythm is regular. It is seen as a regular rhythm. So we find that the ECG can be easily, rate can be found by 1500 divided by number of small squares. Okay, so you check here. One big square, two, three, two small square, three small square. So it is four big squares. Or you can say that 4 into 5, that is 20. So 1500 divided by 20, which comes to be 75. So the rate is 75 beats per minute. Next comes the rhythm. You see there is P wave following every QRS, P wave following every QRS, and proper equal RR interval between all the peaks. So it's clearly a regular rhythm. Rhythm is regular. Next, we check for the axis of this ECG. Among axes, we check the lead 1 and lead AVF. Lead 1 is positive, lead AVF is also positive. Check lead 2, lead 2 is also positive. So we can say that lead 1 positive, lead AVF positive. So we conclude it as a normal axis ranging from -30 to +90. Next comes the P wave. You see the P wave in lead 2 rhythm strip. The P waves are present and almost normal in morphology and duration, less than 3 small squares. So the P waves are present, and also it is normal. Next comes the fifth one is PR interval. In PR interval, we check the normal PR interval is, normally it is 120 to 200 milliseconds. Normally. But here, what is it? We check here clearly in the lead 2. Here, it is 4 small squares. So it comes 4 into 40 milliseconds. That is 160 milliseconds. So it is normal. Okay. So here we have discussed the PR interval, which is small squares, normal, and let's check whether there is any pathological Q waves. In this ECG, we didn't find any pathological Q waves in any of the leads. Next comes the QRS complex. In this ECG, due to rhythm strip, you can see that the QRS complex is two small squares. So we can find easily that the QRS is two small squares.
which is 2 into 0.4, that is 80 milliseconds, which is normal. Then you come to the ST segment. This segment, in ST segment, you check the axis, you check the leads. In lead 1, there is ST segment elevation, it's clearly noted. In ABL, there is ST segment elevation. In V1, elevation of ST segment, V2, V3, V4, V5, and V6. So we found ST segment elevation in almost all chest leads and one and ABL leads. So ST segment elevation, ST elevation. Next, we have ST segment depression. In what all segment you find any ST segment depression or not? We check. In lead 3, there is an ST segment depression. In ABF also, there's a mild ST segment depression. So we can conclude that ST segment depression in lead 3 AVF. In lead 3 and AVF, there is ST segment depression. Next comes the T wave. Lead ECG. When you're checking at the chest leads, you see that in V1 the T wave is elevated. In V2 also elevation of T wave. V3 also elevation of T wave. V4, V5, and V6. V6 there is no much elevation, but you could see that yes, of course there is an elevation. But you see that in lead V1, V2, and V3, the T waves are above the QRS complex. So that we say we will conclude it as a hyperacute T wave. Okay, so you see the T wave elevation in all V1 to V6, hyperacute T waves elevation in V1 to V3. Coming to the final diagnosis, the patient who is a diabetic, complaining of a central chest pain, and seeing all these, diagnose it as an ST segment elevation in my, because in one AVL and most of the chest fields we see ST segment elevation, and the ST segment depression is because of the reciprocal change. So it's a widespread ST elevation in my. What we should here we need a to treat, we need a percutaneous coronary intervention. It's an emergency procedure, otherwise the patient will go for cardiac arrest. So it's clearly seen that the elevation MI in 1 AVL, V5, V6, probably it is an anterolateral ST elevation, but progression may be there, and there is a reciprocal changes in the inferior leads also. So thank you so much.